All right. So just my disclosures here again. And acknowledgement of Dr. Mark Golub, who contributed a case that I used here. All right, so our objectives for this talk, we're going to describe the current and emerging treatment paradigms for rectal cancer, which I think it's important to understand just so you can kind of place your reads in the clinical context and understand how what you say is going to drive management of the patient. We're going to hopefully recognize imaging response patterns after neoadjuvant therapy, and then understand some interpretive pitfalls and protocol optimization strategies. So we'll start with management paradigms. So as you all know, rectal cancer, pelvic MRI has been around for a long time, but the MRI, the sort of clinical staging by MRI drives the initial management. So in the United States, if patients are deemed to have a T1 or T2 tumor, no involved nodes, no evidence of distant metastatic disease, and the tumor margin is adequately far from the sphincter complex, maybe 1 or 2 centimeters, that patient's deemed low risk and can oftentimes go straight to resection. In contrast, if a patient has T3 or 4 disease, they have involved lymph nodes, distant mets, or if the tumor is too close to the sphincter to get a margin without sort of having to resect the sphincter itself, those patients are generally considered high risk, and they tend to undergo neoadjuvant therapy. If resection then becomes feasible after neoadjuvant therapy, then that's usually what happens. In Europe, things are similar, but a little bit different in that, in Europe, patients who have T3 disease, as long as the tumor's in the upper or middle rectum, there's no evidence of extramural vascular invasion. The mesorectal fascia, which is sort of our surrogate for the circumferential resection margin, is uninvolved. Those patients can go directly to surgery. So, similar, but slightly different in terms of those T3 tumors in Europe. Okay. So how are these cancers managed in terms of neoadjuvant therapy? So it used to be that if a patient was deemed to be in that high-risk category, they'd go for neoadjuvant therapy. They get external beam radiation therapy concurrent with a radiosensitizing chemotherapy agent. Then they would go for total mesorectal excision, and then they get this sort of adjuvant or post-operative intensive chemotherapy regimen. Something like FOLFOX is what was typically given. So there's been a movement to provide now what's called total neoadjuvant therapy. So it's basically taking that intensive chemotherapy, which was previously done in the adjuvant setting, and moving it to the neoadjuvant setting. So now these patients are getting their external beam radiation with that radiosensitizing chemo, and then a more intensive chemotherapy regimen, and then they're undergoing total mesorectal excision. So what we found is that with this sort of shift from conventional to TNT, the pathologic complete response rates have risen, from probably around 12% to upwards of 30% with TNT, which then raises the question, if we have high PCR rates, can we identify these PCR pathologic complete responses preoperatively and spare patients unnecessary surgery? So to understand how that process works, I want to introduce this concept of the clinical complete response, or CCR. So what that means is that there's no apparent residual tumor after neoadjuvant therapy. Now, there's no precise definition because it just sort of depends on what studies you perform to assess the response. But generally, it's going to consist of a repeat pelvic MRI, endoscopic evaluation, and digital rectal examination. So the CCR does predict favorable outcomes for patients, but it's an imperfect surrogate for a pathologic complete response. So to this point, as high as 53% of patients who are thought to have a CCR will end up having viable tumor when they end up undergoing the total mesorectal excision. Conversely, maybe 15 to 20% of patients who are deemed not to have a CCR, so perhaps evidence of residual tumor on imaging, will end up having a pathologic complete response when their rectum is taken out. So it's not a perfect surrogate, but it actually performs pretty well in terms of stratifying patient outcomes. Okay, so how does this work? So patients undergo neoadjuvant chemoradiation, so that's that TNT that we talked about. 12 to 16 weeks later, we do our clinical response assessment. So patients get pelvic MRI, lower endoscopy, digital rectal exam. If there's no evidence of residual tumor on any of or if there's evidence of residual tumor, meaning that they don't achieve a CCR, then they'll go for the TME. If they are deemed to have a clinical complete response, then we can do what we call watch and wait. So what's watch and wait? That's also called non-operative management, meaning that patients are just sort of surveilled periodically after the completion of neoadjuvant therapy, and surgery is done only if they have evidence of recurrent tumor at a future point. So why would a patient with a CCR opt for watch and wait? Well, if the surgery that would be required to remove the area where the tumor was located would involve resecting the anal sphincter complex with an APR, then obviously those patients are going to have a lifelong need for an ostomy. If patients are poor surgical candidates, then obviously it would make sense perhaps to try to avoid surgery. But increasingly commonly, we're just seeing that this is patient preference. So, surgery has morbidity and occasionally mortality associated with it, and patients would rather just sort of keep their organ as long as they can, as long as there's no evidence of tumor. But with this sort of strategy, it's really important that we identify residual disease and local regrowth early so that patients can be shunted into effective salvage therapies. And the later we delay the recognition of residual or recurrent disease, the less likely it is that surgery is going to be an effective option at that time. So at our institution, patients, after they're deemed to have a complete clinical response, will get a pelvic MRI every 3 months for 2 years, and then we kind of lengthen that out to every 6 months thereafter. And then at the same intervals, patients are generally getting digital rectal exam and lower endoscopy. In terms of regrowth, so patients who are put on a watch and wait strategy, 24% of those patients will develop tumor regrowth at 2 years. Where are these regrowths located? The vast majority, 97%, are going to be in the rectal wall right at the site where the primary tumor was located. 3% of them will be in the regional lymph nodes. They tend to be the ones that were involved at initial staging. In terms of the timing, so among all the patients who do eventually develop tumor regrowth, 64% of those will be within 1 year and 88% are within 2 years. So that sort of explains why we sort of decrease our frequency as we get out to those later stages of the watch and wait period. So obviously, if you have a mucosal-based regrowth, endoscopy can pick that up and they can biopsy it. But some regrowths happen deeper in the wall. They can happen in the mesorectum. They can happen in the nodes, and we're the ones who have the opportunity to see that and inform the clinicians of it. And then if these patients need salvage therapy, sometimes a transanal local excision is effective, but sometimes patients end up going for the full TME, and then it's been reported that with these salvage therapies, it can get negative margins in almost 90% of cases. All right, technical considerations. So rectal cancer pelvis MRI protocol, we use the same protocol for initial staging as we use for restaging and surveillance. We have patients empty their bladder to reduce ghosting and rectal compression. We use a spasmolytic, in our case glucagon, to reduce GI motility. Some centers will use a mini enema or will instill rectal gel, and that's sort of, I think, helpful mostly for displacing rectal gas and getting rid of some of the sources of artifact that can potentially masquerade or obscure tumor. So these are the sequences, and I'm just going to draw your attention to the ones that I think are most essential for restaging. So, just like at initial staging, we acquire our triplanar, obliqued, high-resolution T2-weighted images without fat suppression, and we try to match the obliquing to what was done at initial staging so we can have an apples-to-apples comparison. And then we include this oblique axial small field of view diffusion weighted sequence, and that's sort of like what is done for prostate, the prostate protocol, and we match that to the obliquity of the oblique axial T2 again, so we can kind of correlate findings across those sequences. We like to generate either by acquiring a native high B value or calculating a high B value, an image with a high B value, so that really increases tumor conspicuity and helps to reduce the signal from fluid in the lumen. And then on the scanners that we have that are capable of accommodating this, we use a readout segmented sequence, so it's multi-shot instead of single-shot diffusion, and that helps to improve tumor signal and reduce distortion related to susceptibility. And then, at initial imaging, like giving, contrast is somewhat controversial. There have been some papers showing that it doesn't really change initial stage. But we do find that it is helpful in the sort of post-treatment setting, especially if our DWI is limited by artifacts. Sometimes you can pick up sites of residual disease there as areas of early post-contrast enhancement. All right, so just kind of show you some of the advantages of having a high B value, either acquired or calculated. So you can see here we've got this sort of W-shaped tumor, not for Wisconsin in this case. But on the DWI with a B value of 600, you can see some signal from that tumor, but we're also still left with a little bit of the signal from the fluid in the lumen. And we go up to a B value of 1,000. You can see that luminal signal is suppressed and that tumor is more conspicuous. And then with the readout segmented DWI, here's a patient who, this was at initial staging actually, but had this tumor, was adjacent to this, segment of rectum that was distended with gas. And you can see on the single shot or conventional diffusion, we get the sort of geometric distortion here, where the tumor seems to be kind of stretched out in the right-left direction. We can see, the diffusion signal from a couple of small lymph nodes here. But on the readout segmented, and this is with a B value of 2,000, sort of multi-shot approach, it takes more time, but you can see here that the diffusion images are better at representing the anatomy of the tumor and are showing signal from even these smaller lymph nodes. So it just goes to show that in the post-treatment setting, these approaches can be helpful as well for identifying sites of residual or recurrent tumor. Okay, restaging principles. So I want to introduce this concept of a MR tumor regression grade, or MRTRG. So this was derived from the Mercury trials. Those were the studies that established the validity of MRI for initial staging of rectal cancer. They went on to sort of include some evaluation of response to therapy. So this is a system that's sort of derived from that trial. The MRTRG is based on T2 weighted images only, so it doesn't incorporate findings on diffusion or post-contrast images. And it's a score that ranges from 1 to 5, 1 being the tumor's completely gone, 5 being there's no response. As you move from 5 to 1, the amount of tumor that's left over is declining, and the amount of fibrosis and mucin that the tumor is replaced with is increasing. So what are the limitations of just using T2 weighted images with the MRTRG? Well, as the tumor regresses, you can get fibrosis that forms, and that generally has low signal on T2 weighted images. But you can also get these pools of mucin that form, and that will sort of give you high signal on T2. Similarly, with in the post-radiation setting, you can get some radiation proctitis, submucosal edema related to that. So the sort of admixture of processes that produce high and low signal can kind of give you intermediate signal, and it can be hard to tell. Are you dealing with residual tumor, or is this just a combination of fibrosis and radiation proctitis? So what's been shown is that if you add diffusion-weighted imaging to your T2-weighted images in the assessment for residual disease, that will increase your specificity, as you can see here, without will increase your sensitivity from like 50 to 85%, and it doesn't appreciably decrease your specificity. So you're not having that many false positives, but you're picking up more residual disease than you otherwise would. Okay, so here's just a schematic showing the various tumor regression grades. So this is this bottom row is pre-treatment, this is post-treatment, and then this is just sort of a cartoon showing what is depicted here. So this tumor, you can see, was treated. We still have a lot of that residual T2 intermediate signal, or that tumor signal, and it doesn't really seem to have changed much. Here's a case where the tumor regressed slightly, but there's still quite a bit of areas of T2 intermediate signal. Sometimes you'll see a little bit of mucin formation or fibrosis. In this case, there wasn't much of it. MRTRG is what we use when we say the tumors responded, substantially. There may be a lot of areas of fibrosis or mucin, but there's still a decent amount of residual tumor signal. MRTRG2, that's indicating that we think we don't see any residual tumor signal. So all that T2 intermediate stuff is gone, but we have a really sort of dense, prominent scar where that tumor once was. And then MRTRG1 means the tumor is entirely gone away, and the rectal wall is totally normalized, or we see sort of a thin scar, as in this case where that tumor was located and sort of diagrammed there. What are some of the things you might see post-treatment on DWI? So here's a patient who had this sort of semi-annular rectal mass, probably some T3 disease there, was diffusion restricting. Patient was treated with neoadjuvant therapy. Now we have uniformly low signal in the rectal wall. There are no focal dark spots on the ADC map, and the wall looks pretty normal in terms of its stratification pattern there. A little bit of perirectal fibrosis where that T3 disease was, but this would be in MRTRG of 1. All right, another case, kind of a long segment lesion, circumferential. This was treated with neoadjuvant therapy. Again, here the wall looks, pretty much normalized on T2, so this would get an MRTRG of 1. Pretty uniformly low signal on diffusion. There are some little areas there, that of higher signal that likely represent the mucosa or the luminal contents. Usually that will have kind of like a stellate appearance. Can kind of look like a Mercedes-Benz sign or a star, whereas residual tumor tends to have kind of a C-shaped or a U-shaped configuration. And again, sort of no focal dark spots on ADC, no evidence of residual tumor. Here's another case, patient with a T3 tumor, was treated with neoadjuvant therapy. And looking at the T2s, you might say, well, a lot of this area, this tumor was, semi-annular, has been replaced with fibrotic material. It looks pretty T2 dark there. Probably some areas of intermediate signal, but when you look at the diffusion, it sort of tells a different story. You can see like a much greater portion of the rectum continues to restrict diffusion. So this patient had quite a bit of residual disease, some response, but still quite a bit of disease left over, and that led the patient to get a TME. Another case here of a lesion extending from probably about 6 o'clock to 12 o'clock, diffusion restricting. This lesion responded quite nicely if you look at the T2. So, this fibrotic scar, leading us to call it an MRTRG2, has formed at the site of that tumor. But when we look at the diffusion weighted images, we see this focal high signal on the DWI and focal low signal on the ADC. So this patient had minimal residual tumor on the diffusion that wasn't picked up by the T2 weighted images only. This was a case of a sort of high rectal cancer in which the diffusion weighted images didn't turn out very well. So this sort of illustrates the situation in which the post-contrast images may be helpful. So this is what the tumor looked like before treatment. So you can see what it looks like on some subtracted sagittal post-contrast images. And, there was a lot of motion artifact here. The rectal wall looked, probably mostly normalized, a little bit maybe asymmetrically thickened along the posterior aspect. But in that same spot where you saw the tumor before, there's this kind of asymmetric, avid early post-contrast enhancement that was suspicious for residual disease, and that was confirmed endoscopically. So I find that to be most helpful when you're not really getting your answer on diffusion. All right, lymph nodes. So what you want to do is you want to evaluate all the sites where there was initially tumor involvement. So, going back to the initial staging study and seeing which nodes were involved, you're going to look at the regional mesorectal nodes. So it's going to be the mesorectal proper nodes, the superior rectal nodes, and the IMA nodes. You're going to look at the regional extra mesorectal nodes. So again, still end disease, but outside of the mesorectal compartment. Those are going to be your obturators and internal iliacs, and then your non-regional extra mesorectal nodes. So those are the other pelvic stations. So you're getting into the external and the common iliacs. The assessment is based on the short axis dimension of the lymph nodes, the regional lymph nodes. So if a node that was thought to be involved initially measures less than 5 millimeters in short axis or has completely disappeared, then we read that as no residual tumor. If it's 5 millimeters or greater, then we suggest the possibility that there is residual tumor. Now, obviously, a size cutoff is never going to be perfect, but this is what the literature has shown to have the best diagnostic accuracy. Unclear if this applies to non-regional nodes. If you had involvement of an external iliac node, for example, that size cutoff is less well established in that setting. So here's an example of a patient who underwent initial staging, had this large extra mesorectal lymph node. You can see that's the mesorectal fascia there, and this node is outside of that. So this is one of those sort of lateral pelvic nodes, an internal iliac. This responded to therapy, but the size after treatment, the short axis was 6 millimeters as opposed to 18 initially. So it's still above that 5 millimeter cutoff. The surgeons, try to avoid doing lateral lymph node dissections because of the associated morbidity when they can. So in this case, the patient just underwent a TME. And then, some number of months later, had a restaging study which showed that this node had substantially increased in size. So that's local tumor regrowth within one of those lateral pelvic nodes. Decrease in nodal size doesn't actually tell you that the node was involved at initial therapy. So even tiny nodes that you would never actually call as being involved, and I mean, who knows if they actually were, but anything that's in that treatment territory, that where the radiation is being administered is going to decrease in size typically. So normal nodes don't like being blasted with radiation either. Okay, what does local regrowth look like? So let's look at some examples in the rectal wall and the mesorectum. So T2 weighted images, this is what this tumor looked like at initial staging, circumferential T2 intermediate signal, extension into the mesorectal fat, all the way over there with involvement of the mesorectal fascia. At restaging, the patient was deemed to have a complete imaging response. This was called an MRTRG2. You can see that T2 intermediate signal has been replaced with low T2 signal, and that extends all the way out to where that mesorectal fascia was involved. However, on surveillance, this patient was placed on non-operative management. You can see that T2 intermediate signal has regrown within the wall and also out in the mesorectum, and is probably all the way out to the mesorectal fascia. So this patient was taken for a TME with an extended margin along the right anterolateral aspect to try to get a negative margin with that tumor in the typical dissection plane. Another example of regrowth, so this patient had a complete imaging response. This was a low rectal tumor with extension into the anal canal. No evidence of disease. It looks like normal anal canal anatomy there. Nothing focally diffusion restricting, nothing dark on ADC. But on follow-up, developed this kind of T2 intermediate nodule that you see right there. It's kind of disrupting the anatomy of the anal canal. There was focal high signal on the high B value diffusion and low signal on the ADC. So that's true diffusion restriction, and that was a local regrowth that was confirmed. I mentioned that there's some cases in which these regrowths are not visible endoscopically. So certainly, if you had regrowth sort of just in this area but not in this area, the endoscopist is not going to pick up on that. Similarly, lymph nodes, they generally can't see very far from the rectum with even if they do endoscopic ultrasound. So this is a case of a patient who at initial staging had an involved superior rectal lymph node, as you can see here. That node resolved, wasn't even really measurable after neoadjuvant therapy. The tumor had also regressed. This was deemed a complete imaging response. But on follow-up, you can see here that node has grown back and is diffusion restricting. So that sort of resulted in this patient undergoing the total mesorectal excision. Pearls and pitfalls. Okay, so we talked about submucosal edema and how that can kind of mimic tumor. And that's basically radiation therapy, in addition to causing the tumor to regress, will cause some inflammatory changes in the adjacent rectum. So in this case, you can see that tumor has been replaced by this T2 dark scar here on the coronals as well, but in the flanking segments of the rectum above and below, as well as the uninvolved opposite wall, you can see there's this kind of high submucosal signal that, sort of in that T2 intermediate range. So that's submucosal edema from radiation proctitis, and that can mimic tumor on the T2 weighted images. But the things to notice, it tends to spare the actual tumor site. You can see here, this is where the tumor was, it's regressed, but it's sort of this long segment of involvement above and below where the tumor was, or in the opposite wall, where the tumor was not initially involving. So it tends to spare the site of the initial tumor. Oftentimes this is apparent on the very first restaging study, but occasionally it can present in a delayed fashion. So I've seen this sort of crop up 9 to 12 months after the completion of radiation therapy in a patient on non-operative management as well. So really correlating with the initial MR and knowing what the distribution of tumor was is important for avoiding this pitfall. So this is kind of like a nice little way to approach this. So looking at the internal structures and their signal intensity can kind of help sort this out. So at the top end of this signal intensity spectrum, we have luminal fluid, as you can see there in the bladder, in the rectal lumen. And then the submucosal edema of the sort of uninvolved portion of the rectum tends to have a signal that's a little bit lower than that, like pretty similar to what you see out here in the mesorectal fat. So those are usually relatively isointense to each other. At the low end of the spectrum, we have our tumor scar, which is very dark, and then the muscularis layer of the rectum, which tends to be like a little bit less hypointense. And then anything that's sort of between the mesorectal fat and the muscularis propria in terms of signal, you can see like right here, that's sort of more hyperintense than the muscularis, but it's darker than the fat. That's going to be concerning for residual tumor. All right, T2 shine through. So what is that? I think probably most people are familiar with that phenomenon. So here's a patient who had this semiannular rectal mass, responded nicely to therapy. You can see like kind of a focal T2 hypointense scar right there. There was some focal high signal on the high B value diffusion weighted images, but that corresponded with a bright spot on the ADC. So this is T2 shine through rather than true diffusion restriction. And this is just due to T2 effects. So oftentimes, but not always, if you look at the T2 weighted images, you'll see a correlate for that. You'll see like this is the pattern of signal inside of the lumen of the rectum, but you don't always find a good explanation for that. Obviously the rectum can kind of like change in orientation between sequences, but it's really important to inspect the DWI and the ADC to avoid this pitfall. Mucinous degeneration. Mucinous rectal cancers are a whole separate beast, and like you give a whole talk about that. And we've been, a lot of this talk was sort of predicated on the assumption that these are non-mucinous lesions because it's just sort of a very different scenario for the mucinous. But this was a case of a non-mucinous rectal cancer. It has kind of a 3 shape to it. And after neoadjuvant therapy, that tumor had regressed, but in the area where kind of the center of the tumor was located, we have this high signal that looks pretty similar to like that signal there in these seminal vesicles. So that's mucinous degeneration. It's one possible outcome of tumor regression. More commonly, you see scar formation. Sometimes you can see both. There was some thought that this actually, this mucinous degeneration, indicated that the patient was likely to have a good prognosis. But the most recent literature on that topic would indicate that this really is not of much prognostic value. It's just one of the ways in which tumors can respond to treatment. And then T2 dark through. So this is the counterpart to T2 shine through that I mentioned. So here's a tumor that was treated with neoadjuvant therapy, was replaced with this really T2 dark scar right here, some of that radiation proctitis on the opposite wall. When you look at the ADC map, you can see there's this area of like kind of focally dark signal, kind of C-shaped or U-shaped. So, looking at the ADC alone, you might think, well, is this residual diffusion restriction? But when you look at the high B value diffusion weighted images, you don't see that at all. The rectal wall looks uniform throughout. So what this is T2 dark through. So really anything that's really T2 dark on your small field of view images can manifest as an area of low signal on the ADC. But when you look at the actual diffusion trace images, you won't see a correlate for that. Usually it's in the setting of a really robust T2 dark scar on T2 weighted images. And another pitfall, so sometimes you'll see some signal in portions of the rectum that were not involved by initial tumor. And like I said, residual disease, recurrent disease, almost always going to occur exactly where the tumor was at initial staging. So this tumor responded nicely to therapy. You can kind of see that thin scar right where the tumor was. But on the opposite wall, maybe around like the 7 or 8 o'clock position, you can see there's this focal diffusion restriction, right? But if you look at the initial staging, like that's the part of the wall that wasn't involved by tumor, right? So when you see that kind of pattern, that's almost certainly going to be due to artifact rather than residual disease. You put the same finding over here on the opposite side, and we're calling that residual tumor. Here's some cases of artifactual high signal on diffusion weighted imaging related to rectal gas. You can see how there's some asymmetric signal here in the sort of right posterolateral wall of the rectum, and that could be confused for tumor. In this case, the tumor was substantially higher within the rectum. So you really just have to know where the tumor was, and that helps you to dismiss other areas of potential abnormality as being artifactual. Okay, and then finally, I just want to give you kind of a brief interpretive strategy here. So how do I lay out these cases when I'm doing a rectal cancer treatment response assessment? So I've got my 2 monitors here. I'm just kind of diagramming this for you. So I've got my current study here, laid out like this: T2 diffusion ADC immediate prior, the first post-chemo radiation scan, and then the initial staging study. I'm going to collect my treatment history. So what was the patient treated with initially? Were there any recent endoscopies or interventions? What did they show? I'm going to determine the tumor locations, both the primary tumor and the involved lymph nodes at initial staging, to know where it's going to be highest yield to look for residual or recurrent disease. I'm going to look at my T2s and look for that sort of T2 intermediate tumor signal at the primary tumor site. And I'm going to inspect my diffusion images and ADC map for focal high and low signal respectively at the primary tumor site. I'm going to measure my previously involved lymph nodes in short axis to see if they've, on the initial staging, have dropped below that 5 millimeter point, or are they increasing in size during the watch and wait period. And then I'm going to review my other sequences, the post-con T1s, for evidence of that sort of early hyperenhancement. And then categorizing the overall disease status on imaging, knowing that you can't really call a CCR based on MR alone because the CCR depends on what the DRE and the endoscopy show. But what I like to do is, I generally don't get too granular with the MR TRG, because really what the surgeons care about is do we see any evidence that there's still tumor, or is it a complete imaging response? So complete imaging response, I say that when I think that we're kind of in those MR-TRG 1 or 2 categories. There's no focal abnormality on diffusion. And those patients, assuming the endoscopy is negative, can go for watch and wait if they so choose. Occasionally, you'll see like a tumor where you're like, it's mostly gone, but maybe there's a little bit there. I might give that an MR-TRG 3, or maybe there's a little focus of diffusion restriction. Sometimes those patients can actually be treated with some more chemo, and they can actually get to that point of having a CCR and can be surveilled. So these patients may go for watch and wait, or they may get after more chemo, or they may just go for resection. And then when you have an incomplete imaging response, that's MR-TRG 4 to 5 or substantial diffusion restriction. That basically requires the patient to go to surgery. So this is kind of how I break it down, incorporating the T2 and diffusion findings, categorizing it as complete, near complete, or incomplete response. So to review, with the sort of new TNT regimen and the increasing pathologic response rates, more and more patients are being managed with this watch and wait strategy, which means that we as radiologists are going to be reading more and more MRIs for rectal cancer response assessment and surveilling for recurrence. To optimize your protocol, you want to acquire those triplanar, high-resolution, small field of view T2s without fat suppression. You want to match what you did at initial staging. You want to use an oblique axial small field of view T2 that's sort of matched to your small field of view diffusion that's matched to your T2, and you want a high B value to give you that tumor conspicuity and suppress the luminal signal. And then those post-contrast T1s may be helpful if your diffusion is suboptimal. You want to use a systematic interpretation incorporating the sort of MR-TRG concepts and the diffusion concepts that I described to do your image response assessment. And then you can avoid common pitfalls by evaluating the DWI, ADC, and small field of view T2s in unison, as I have suggested, focusing on the sites of initial tumor involvement and knowing that 97% of recurrences are going to happen right where the primary tumor was. If you see an abnormality that's anywhere else in the rectum, it's almost certainly going to be artifact. And then I think having multiple priors is available. If you see something you're not quite certain about, looking at even older studies, sometimes you can see a more convincing trend. That's the end of my talk.